Hello, I am Dr. Ahmed Abdelal, and we're going to speak about the anatomy and physiology of respiration. This is part 2. The previous video is available on YouTube, and now we're going to speak about the muscles of respiration. Broadly, the muscles of respiration are two broad categories. Number one is the primary muscle of respiration. You notice that I'm saying primary muscle one, and that is the diaphragm. The diaphragm, number one, is the muscle that enables the thorax to expand, and the lungs also expand with the thorax, and the expansion is vertical. I mentioned previously that vertical expansion accounts for most of the expansion of the volume during breathing. And the diaphragm is the primary muscle that mostly works while we are breathing at rest, because we do not need to exert much effort at rest. So when we speak about speech respiration, we have to involve the accessory muscles of inhalation and the accessory muscles of exhalation. So again, the diaphragm is the primary muscle of respiration. And in addition to that, when we speak, we have to involve that whole set of accessory or assisting muscles of respiration. So now we are looking at a superior view of the diaphragm. The person is looking facing this way, so that here's the anterior. This is a transverse cut of the sternum, and posteriorly this is the spinal column. And the diaphragm here is like a dome, and you're looking at the top of the dome, looking down at it. So you notice that this white structure here, that is called the central tendon. And a tendon is made of fibrous connective tissue that is tough. And out of the central tendon, the muscles of the diaphragm radiate. They spread out anteriorly and inferiorly and laterally and posteriorly. The structures that are involved in the diaphragm are the phrenic nerve, left and right and left. The phrenic nerves are the nerves that branch out of cranial nerve number 10, or the vagus nerve, and they enable the diaphragm to contract. When it contracts, it descends. Originally, when the person is born, there is no air in the lungs. And in that position, the diaphragm is up like this. And on top of the diaphragm, you have the two lungs sitting. So as soon as the person is born to take the first breath, the diaphragm has to descend, to contract and descend. From that moment on, the diaphragm continues to go up for expiration, go down for inhalation. Then we have the diaphragmatic pleura that I explained in detail in the first video of this unit. The diaphragm, again, the superior surface of it is like a dome, and the entire diaphragm itself is encased in a diaphragmatic pleura, a thin, very thin layer that is transparent, and it is filled with moisture and the fluid surfactant. And then on top of that, you have one lung sitting here and the other lung sitting here. And we said last time that the pulmonary pleura, the lining of the lungs, the inferior surface of it comes in contact with the diaphragmatic pleura. When you put them together, there will be a tiny space in between the pleural cavity, and inside of the pleural cavity there are two conditions that will make the pleural cavities, both of them, stick together. These two conditions are the negative air pressure in between and surfactant. So that creates the diaphragmatic pulmonary linkage that causes the inferior surfaces of the lungs to stick to the superior surface of the diaphragm. So whenever the diaphragm contracts and goes down, it pulls with it the lungs. And this acts like a syringe. The pump of the syringe is, the top of it is like the diaphragm. So when you pull the syringe handle down and the pump down, that is going to expand the space inside of the syringe. And when it goes up, then you make the space or the volume smaller. So that is the action of the diaphragm. You could see it here. It is like two little domes connected together, or like a parachute. And that parachute doesn't have any anatomic connections on the sides or the top or anywhere, except, with any other structure. It's like a balloon that the top of it is freely, free, and it can go up and down without having to be anchored to anything. The only thing that holds it in place are the edges. All the edges, inferior edges of the diaphragm, are attached to the inferior edges of the thorax. So anteriorly, from the front, you have the frontal piece of the diaphragm is attached to the anterior surface of the xiphoid process. That little tip of bone here and front at the bottom of the sternum is called the xiphoid process. So anteriorly, the diaphragm is attached to the xiphoid process, and then to the inner borders of the anterior segments of ribs number 7. Here is, let's see, 1, 2, 3, 4, 5, 6, 7. So the cartilage segments of ribs number 7, 8, 9, 10, and then you go down, it also connects to, on the side, to ribs number 11 and 12. So posteriorly, it is going to connect or insert onto the, it has a connection to the lumbar vertebrae, the 5 lumbar vertebrae. And on the side here also, it is connected to ribs number 10, 11, and 12. Here's number 10, 11, and 12. If you click on this video, you'll see the parachute game that children play at school. You notice when they get it up and it becomes like a dome, kids are holding on the edges, and in order to bring down that dome, they have to pull two things: pull down and out. When you pull down and out, the top of the dome comes down. So the diaphragm, let's go back here. The diaphragm is attached to the inferior borders of the thorax. When you elevate the thorax, as you elevate the thorax, and it expands anterior, posteriorly, and laterally, that is going to spread out, and it will pull on the edges of the diaphragm. As soon as this is done and the edges are pulled, immediately the diaphragm itself is going to resist, and as a result, it's going to contract, and it pulls against the central tendon, and as a result, it starts to descend and flatten. So that creates the vertical expansion that allows the lungs to have a greater volume. When you have a greater volume, you have negative air pressure. That negative air pressure will cause suction, and it will suck the air in from the outside space, and the air will flow into the nose or the mouth, down and into the lungs, until the point of equilibrium is achieved, and that is inhalation. So the opposite is true. When the diaphragm goes up, then it contributes to compressing the lungs. At the same time, the thorax will collapse and come down, so the lungs are compressed from all over all the sides, and that will increase pulmonary pressure. And the increase in, it will decrease the volume, and that will increase pulmonary pressure, and the increased pressure will drive the air out, and the air will continue to stream out until equilibrium is achieved, and that is the end of exhalation, and then inhalation will start again. So now we are going to move to the accessory muscles of inspiration. After that, we'll speak about the accessory muscles of expiration, and then summarize the process of inhalation and exhalation again. So there are the accessory muscles of inspiration include the anterior thoracic muscles in the front of the chest, and then the posterior thoracic muscles and on back of the thorax, and the neck muscles, shoulder and upper arm muscles, and then back muscles that are below the thorax. So the first one we look at is the external intercostal muscle. The external intercostal, it functions as a unit. It functions as one unit. It is, when you say inter, means in between. Costa means rib. Intercostal means in between ribs. Okay, so if you have, look here at the diagram, you have two ribs, 1, 2, and you have 3 sets of muscles that are between the ribs. So here's one. You notice the orientation. It originates on the superior surface or margin of the lower rib and courses laterally out and laterally. The one inside of it or behind it is the internal intercostal. So that internal intercostal, see the orientation is different. And then there's another set, it's called the innermost intercostal. So actually, made a little error here. The external intercostals originate on the inferior outer border of one rib, like this, and they course inferiorly and medially. They go down and medially to insert on the superior outer margin of the rib that is below. Because now, think about it. It will make sense that if you want to lift, we said muscles can only do one thing. Muscles can only pull. Okay? So if you want to pull something up, you have to have the origin. Muscles pull toward their origin. You have to have the origin above. And then whatever attaches to the muscle then is pulled toward the origin. And if you want to pull a structure down, you have to put the muscle origin below. So you can outermost layer that is in between two ribs originate on the bony segment. Recall that a rib has two pieces, a bony piece and a cartilage piece. The cartilage piece is called the chondral segment of the rib, chondral segment of the rib. And the bony segment is called the osseous segment of the rib. So the external intercostal muscle is a set of muscles muscle segments that are in between ribs. All the ribs have, each two have one segment, and all of these are called the external intercostal muscles. They act together as one unit. Let me show you what they look like. They are all here. All are here. So they, as you could see, they are oriented. They descend, come down from the inferior border of a rib, come down and slant toward, medially toward the center, medially and inferiorly, obliquely. Say obliquely like this. And all of these act together as one movement, and they elevate the ribs, all of them together. So they are powerful muscles or the external intercostal muscle as a unit. It is a powerful muscle of inhalation to lift up the thorax in the front. These muscles are innervated by the spinal nerves that go from the thoracic vertebra 1 throughout thoracic vertebra 11. And again, each segment of them originates on the inferior outer border of one rib and courses inferiorly and medially to insert on the superior outer margin of the rib that is below it. Okay, you need to understand and you need to memorize the origin of muscles and the insertion of muscles, keeping in mind that a muscle always pulls in the direction toward its root. So the function of these muscles, the external intercostal muscles or muscle, is to elevate the thorax. It's going to pull on these ribs up. You are going to change their orientation. Instead of oblique or slanted, you are going to make them more transverse. When you do that, you are automatically expanding the thoracic, the thorax, expanding forward. We call this antero-posterior expansion. And then at the same time, because there's a lot of cartilage in the bottom on the inferior segment of the thorax in the front, that allows for a greater expansion. So as a result, the thorax is also expanded laterally or transversely. And recall that because of the parietal pulmonary linkage, pleural linkage that I explained before, because of that, and because the lung walls are sticking to the interior surfaces or of the thoracic wall, then that keeps the lungs inflated all the time. At the same time, whenever the thorax expands anteroposteriorly and transversely, then the lungs also expand with it in the same way. So now we're going to look at the accessory muscles of inspiration in terms of, we'll move on to the internal intercostal muscles. If you say the internal intercostal muscles, there are two categories of them. There are two sets, and each set does a different job. They do the opposite of each other. So if I say to you, ask you a question about, and then you say, oh, the intercostal muscle does that, your answer will not count for anything. The intercostal muscles are two sets. One involves the osseous segment of ribs, and one involves the chondral segment. See the chondral segment of ribs here. So what you see here is the interchondral segment, the segment that is between the cartilages. See the arrow points up. It means that the muscle is pulling up. When you see that, without even having anyone explain to you, you see the arrow pointing up, it means the origin of these sets of muscles originate on the inferior margin of a rib, and they insert onto the superior margin of the rib that is below it. So you contract, you pull the ribs up. So let me go back and show you here. This is the muscle. This is the internal intercostal, but that is the interosseous segment of it. Okay, that is a muscle of exhalation. Okay, we're not speaking about this one now. We're speaking about the muscle that is connecting the pieces of cartilage in the front to each other. So, but when you say internal, again, here's another one, and we are focusing now on muscles of inhalation and the interchondral segment of the internal intercostals. This segment here and the one that would be here, these are muscles of inhalation. They elevate the front of the thorax. Now, when these muscles will do, this muscle is very important. What it does is, as it elevates the chondral segment, as it elevates or pulls up these pieces of the frontal pieces of the ribs, which are cartilage pieces, it will twist them. It will twist them upward like this. So you have all of them here. The ribs basically are connected on. Many of them are connected onto the sternum. So when you elevate the bony segment of the ribs, and together you elevate the interchondral segment, the cartilage will twist. It will twist like this. It will be twisted like this. We call this torquing. Torquing. You basically load it, and as you lift that up and you twist you allow for twisting the cartilage without changing the position of the sternum, and that gives stability. So now, as you keep this twisted and the lungs are inflated, when it is time to relax and to start exhaling, then the pieces of cartilage are going to untorque. They will snap back into their original shape, and by snapping back, they compress the thorax and pull it and bring it down and in. This movement is critical. So make sure when you describe the anatomy and the function of the interchondral segment of the intercostal muscles, then make sure to state that it exclusively connects the segments of the cartilage segments of the ribs, and know where the origin is, where the insertion is, in what direction these muscles are going to pull when they contract, and need to mention the torquing aspect that results from this action of this muscle, because that torquing is going to be a powerful force for expiration, a powerful passive force for expiration. Now you loaded the energy and then you get it back when you exhale. So far we have spoken about the external intercostal muscles, and then now we spoke about the internal interchondral segment of the internal intercostals. Now, from the posterior aspect of the thorax, we have the levatorus castorum. It is a muscle that has several segments, and it lies along the vertebral column and the ribs. So these segments here. The levatorus, from the name levatorus, elevator, levatorus means the lifter. Castorum means ribs. It means the rib lifter. So the segments of it originate on the transverse process of the cervical rib number 7. So that is a lowest vertebra of the neck. And the transverse process is, see that little wing here, it's called the transverse process. So one rib, articulates here and goes out and curves around. The other rib articulates. So the first one originates on the 7th cervical vertebra, and then they keep going down, see here, and they down to the 11th thoracic vertebra. Each muscle, each levator-scastorum muscle, each segment of it has two parts. One is called the brevis, which is the brief or small, and one is called the longus, or the long muscle. And both of these are segments of one single muscle that is levator-scastorum. Even though all of these sets together, they function as one unit, and this is why they are treated as a single unit of muscle. Or you can say levator-scastorum. All of this is the levator-scastorum, but each segment of it consists of two little segments, again, the brevis and the longus. The brevis inserts onto the tubercle of the rib that is immediately below the vertebra. So the first, and then the first segment, and then it goes down to the first rib. And then the longus is going to originate on the same spot, 7th cervical vertebra. I'm speaking about the first part of it. And then it leaves the first rib and it goes to the second rib. So it skips one rib and inserts onto the next one. Because it is longer, it is going to play a bigger role. It's more powerful. And both segments, if say for example this muscle here, the top segment that originate on the C7, both segments are innervated by the spinal nerve, intercostal nerve that comes out from that vertebra. Then we look at the serratus posterior. The serratus posterior involves two sets of muscles, and each set does a different job. So it is important. Again, if I ask you a question and then you say, oh, the serratus posterior does that, your answer doesn't mean anything. You have to tell me, is it the serratus posterior superior, or is it the serratus posterior inferior? Because again, each one's job. The top segment is the serratus posterior superior, and obviously from the orientation of it, it originates on the vertebrae, but it courses inferiorly and outward. And then when it pulls, it's going to pull up. So you know when you pull up, that is for inhalation. The set that is below, that is for exhalation, because you need to pull back and in. So now we're going to speak about the serratus posterior superior. And that is again part of the inhalation muscles. So it originates on the spinous process of C7, the lowest vertebra of the neck, and the next segment originates on T1, and then the one after T2, and then T3. And each one of these is going to insert onto the the posterior angles of ribs number 2, 3, 4, and 5. Because of you need to pull up. So it makes sense that the root is slightly higher than the insertion. So when the contraction takes place, it's going to elevate. It will be pulling the back of the ribs from behind. So again, the function is to elevate the thorax, the posterior from the back. Now we speak about neck muscles, and these are powerful muscles of inhalation. They are obviously, originating from the top, and they attach to the thorax from the top, so they will elevate the entire thorax. So two particular sets are critical, and the first one is the sternocleidomastoid. The name seems like, complex, but if you think about it, it will make sense and it will be easier to remember. I'll explain. And then the scalenes, or the scalenus anterior, middle, and posterior. So the sternocleidomastoid, sternum is this bone, sternum. And this muscle breaks the rule in terms of, I told you insertion and origin, and the muscle always contracts and toward its root. But this one is a little bit, and the name of it, is a little bit different than other muscles. Typically, muscles, when they're a blend of two names, muscles. The first part of the muscle it speaks about the origin, and the second part speaks about the insertion. Many muscles, are named like that. But this muscle, because it involves 3 connection points, is a little bit different. So the mastoid is a bone, part of your temporal bone, that is behind your ear. That is the mastoid process, or mastoid bone. And this muscle connects on it. But there's also a connection on the clavicle and a connection on the sternum. So this is where the name came from. Sternocleido, and then mastoid. But again, we know that the muscle is when it contracts, it pulls up. But it pulls up 2 things. It pulls up the clavicle, and it pulls up the sternum when it contracts. So when you see, you can see here. This is your muscle. And if you feel, you're going to find it comes down as one branch, one muscle, and then it bifurcates, it splits. And then one piece is going to connect onto the clavicle, the proximal segment that is close to the center of the body, and the other segment will connect onto the lateral superior margin of the sternum. So here's the muscle. As it starts as one unit out of the mastoid, comes down, and then branches into 2 pieces. One goes to the clavicle, one goes to the to the manubrium of the sternum. So when you contract, the unilateral contraction is going to pull the neck toward the side of the muscle. So this muscle is here. I'm sorry, here. When it contracts, it will pull the head toward itself. So neck rotation, unilateral contraction of the sternocleidomastoid produces neck rotation. When you fixate and activate both, that's bilateral contraction, that will elevate the chest. And if you can do this, but put your hands on your shoulder bones here, on the clavicles, and take a deep breath and see what happens. A deep breath. you immediately start to elevate. But that requires unilateral contraction. So the scalenes, or the scalenus, or sometimes scaleni, that's rare, but scalenes or the scalenus muscle, these are lateral neck muscles, as you could see. They originate on the transverse processes C2, neck muscle neck vertebra number 2, C2, and then 3, 4, 5, 6, 2, 3, 4, 5, 6, and 7. So C7 here. And they insert onto, so they have many, like several points of origin, but they insert only on 2 ribs. They only insert on ribs number 1 and 2. So 1 and 2. So these are powerful lifters of the thorax from the sides. And they also contribute to neck rotation. You can see them here. Very powerful and rotating the neck and the head, and also they contribute to the vertical expansion of the thorax. And then we have the upper and shoulder muscles, and these are easy to spot. Yeah, the big one here on the chest, that is called the pectoralis majora, or major. And then if you peel it off, underneath you will find the muscle that has 3 branches like this. That is called the pectoralis minor. And both of them are powerful lifters of the thorax. Then we have the serratus anterior. When you say serratus anterior, that implies there's another serratus, that's posterior. The serratus anterior is a muscle of inhalation. The other one is a muscle of exhalation. So the serratus anterior, serratus, there's a word that has to do with it that we use daily. When you buy silver foil, there's an edge. We call it serrated edge. Serratus means saw. Serrated means it has teeth like a saw. So you could see here the shape of it, is like a saw. So again, this muscle is a powerful muscle. This is it shows a bigger view of the pectoralis minor, and this is the serratus anterior, and all of these contribute to the elevation of the thorax, basically from the side or the front. You can think of the processes of inhalation and exhalation as this way. You have a hill, and you want to roll a stone, a big rock up the hill. So you roll it. Obviously, as you keep rolling it, it takes a lot of energy. You push and push. You exert more force. And when you bring the rock to the top of the hill, now you have loaded it with potential energy. When you tip it over and let it go down, you don't have to do much. All you do, just tip it, and it will go down its gradient. Naturally, it will roll down because you simply gave it energy by bringing it to the top of the hill. Inhalation is like this. Inhalation involves lifting up, heavy lifting of the thorax from the front, sides, and back, and you are lifting up. The diaphragm at the same time is out of its split. It is contracted and it's going down. When the diaphragm is down and the thorax is elevated, and lifted up, it is expanded forward and sideways. All of this is going to contribute to pushing down on the abdominal viscera, your intestines, your stomach, your lungs. Your stomach and the intestines and visceral organs. They will be compressed down. So where do they go? They are going to bulge out. So the muscles of the stomach, or the anterior muscles of the abdominal cavity, are going to bend out like this. because the diaphragm is compressing the organs. So now everything is loaded in a way, once you let go, once the muscles of inhalation relax, then everything is going to begin to compress back, compress the lungs, and that is going to reduce the volume, and then that will create, increase the pressure. And it will increase the pressure, and that will force the air out. As the air goes out, you valve it with your vocal folds, and you generate speech. You can do the same thing if you have a balloon and blow it, and then hold the neck and stretch it. The force of the air is going to vibrate the edges of the neck of the balloon. It will make a buzz, similar to the buzz we make with our vocal folds. So during quiet breathing, there are passive forces that squeeze the air out of our lungs. However, so there are three forces I'm going to discuss. However, when you speak, you require more energy, and you require more control over the thorax and the respiration process, and you are definitely going to inhale to use accessory muscles of expiration. So expiration requires two things: passive forces that I just explained, and in addition to that, accessory muscles of expiration. You need to understand what these passive forces are, and what each one exactly acts upon, and what the outcome of their activity is. Okay, so you need to if you take notes, you will understand the questions that you will have. So you need to understand the passive forces, what each force is, what it will act upon, and what the outcome of that action is. So the first thing, gravity. We have lifted up the thorax. The thorax is bone, cartilage, muscle covering the thorax. So it is a very heavy structure. These muscles that are holding it and lifting it up to expand the thorax, once they relax, the gravity will pull the thorax down. So gravity will act on the thorax right as the muscles of inhalation relax. What does that do? It compresses the lungs from the sides and from the top. The second force, the second passive force, is the untorquing process. Remember, when the cartilage segments are twisted upward, when the muscles relax, the torquing is going to be reversed. So the chondral segments of the ribs will untorque. They will snap forward and down, and they will pull the front of the thorax down and in. So that will contribute to compressing the thorax and the lungs. Elastic recoil will act on more than one thing. Elastic recoil, it means when you stretch, you let go, things will go back to their original position. First, we have the lung tissue, stretchy and rubbery, bounce back to where it was. So when the lungs are being compressed, the tissue of the lungs itself would want to go back to its relaxed state. So elastic recoil will act on the lung tissue by making it shrink back. Now, this is number one. Two, the diaphragm originally in inhalation contracts to go down. So now it is distorted and it's going down and flattened. Now, when it is time, it relaxes, it is going to need to go upward again. Naturally, it wants to go back to its position. The reason it is able to go back is elastic recoil. The third set or the third thing that the elastic recoil acts upon are the abdominal muscles. The abdominal muscles, when the diaphragm originally compressed the abdominal viscera, that pushed them down, the abdominal organs down, and that pushed the muscles of the abdomen forward. So this way it distorted them, pushed them out of shape. Because of elasticity, when the diaphragm rises, the muscles of the abdomen become vertical again. They are compressed in again. They go back. As they go back, they push on the abdominal organs, and that is going to assist the diaphragm as it goes up. So it is very, very important that you understand that elastic recoil acts on three things, and you need to explain how and the outcome of each. And also, so now the three passive forces of exhalation, they only act in exhalation, and these are gravity, untorquing, and elastic recoil, because they are passive forces that will enable you to reap the energy that you loaded initially when you were lifting and doing the inhalation process, and now you are reversing the process. So the active forces of inhalation include a set of muscles that will pull the thorax inward and downward and from the side and back, and all of them to compress the thorax, which means to compress the lungs and to squeeze the air, the volume, to make it smaller. And as it becomes smaller, the air will stream out, and the air will continue to stream out until the point of equilibrium is reached. And this is where the process halts momentarily and for a few seconds, and then the brainstem mechanisms are going to switch from exhalation to inhalation. So these active muscles or active forces of exhalation, we use them during speech because speech is an effortful process, and these include ribcage or thoracic muscles, internal intercostal muscles, particularly the interosseous segment that is between the ribs, the middle segment that I showed previously, but the one that connects the bony segment of ribs together. And then the transverse thoracic, subcostal muscles, and then you have serratus posterior, inferior, and then we have the abdominal muscles. So here, the anterior and lateral muscles. First, we begin with the internal intercostal muscle, and that is in the middle here. Let's see, we're speaking about exhalation, so it means all the muscles have to be below the origin has to be lower than the insertion, so that when you pull, you are going to bring the thorax down and in. So this is the internal intercostal muscle, especially the interosseous segment. It is very important to distinguish and to state the name. It is not enough to say the internal intercostal does blah, blah, blah. That will not give you, it is not beneficial. You have to say the interosseous segment of the internal intercostal does this and this. The interchondral segment of the internal intercostal does this or that, because they do opposite jobs. So these segments originate on the superior margin of a rib, and they course superiorly and medially toward in the direction of the center of the body. So when they pull, they will pull in and down. They are innervated by the intercostal nerves, of course, and they act as one single segment. All of these are going to act as a single sheet, and the other ones on the other side, all of them will act at once as one single set of muscles. So this here, and this is all the muscles together. As you can see, the arrow points down. It means the origin is down. It means that the movement to pull the thorax, it will pull it down and in. That contributes to supporting and protecting the thorax and maintaining the space between ribs. You don't want ribs to collapse. They depress the thorax, and that again, when you depress the thorax, you decrease its volume. When you decrease the volume, that is going to decrease the volume of the lungs, and that will increase the pressure in the lungs, and the increased pressure will force the air out. And then we have the anterior and lateral muscles. For that, we look at the transversus thoracis. The transversus thoracis is inside. What you are looking at here, if you imagine you take the magic school bus, you get inside of the thorax and you see it from the interior. This is the inside, this is the sternum from inside, okay? And these are the inside of the ribs. You can see it cut here, the thorax. So the transversus thoracis, the segments originate on the inner lateral surfaces, inside lateral surfaces of the sternum, the body of the sternum, and they course superiorly and attach into the chondral segments, the cartilage segments of ribs, number 2, 3, 4, 5, and 6. So we notice we did not involve number 1. So you get ribs number 2, 3, 4, 5, and 6. So when they contract, they reduce, they pull the anterior parts of the ribs in, and the cartilage segments in and down, and that basically reverses the function, the job, the work of the internal interchondral segment of the internal intercostals that lifted them during inhalation. So the transversus thoracis reverses that process and brings the frontal aspect of the thorax in and down to compress the lungs. And that contributes to increasing pressure and expelling the air. Then we have subcostal muscles. Sub means beneath. This is the back of the thorax. This is the spinal column. And you can see, the ribs. So the subcostal muscles originate on the inner posterior wall of the thorax, posterior and inner inside, and they originate on the margin of one rib, and they course superiorly and laterally to attach on ribs that are above. So they run laterally or outward to insert onto one or more ribs above them, because you want to pull down, and when they pull down, they pull in as well. So they pull the ribs inward and downward, especially as you could see, as they connect into one or more of the ribs. They are quite powerful. And then the serratus posterior inferior, we mentioned before that the serratus posterior anterior is part of the inhalation muscles, and this one, serratus posterior inferior here, that is going to act to pull down the thorax, the lower segment of the thorax, in and down. And it originates, that segments of it originates on the spinous process, or this area of the vertebra is called the spinous process. You can touch it. You put your hand in the center of your back, and all of them are stacked together. These the spinous processes of every vertebra. So the first segment originates on the spinous process of thoracic vertebra number 11, and then 12. And then the lumbar vertebrae 1, 2, and 3, lumbar vertebrae. So this is the origin. They radiate or they course laterally and superiorly, slightly superiorly, to ribs number 8, 9, 10, 11, and 12. And when they contract, they bring these ribs in and down. Then the abdominal muscles are very powerful compressors. And we have the transversus abdominis, quadratus lumborum, rectus abdominis. So I'm going to show them to you all in the last slide here. And we have internal oblique abdominis and external oblique abdominis. The transversus abdominis here is an inner kind of muscle of the abdomen, inner sheath. And you can see there's the internal oblique is covering it, external to it. And then the external oblique is the outermost layer. So 3 different layers of muscles. And then you have the rectus abdominis that connects the inferior segment of the thorax, basically going down to the pelvis. And that is very important for flexion. When you contract, it makes you bend your thorax forward. By doing so, you compress the abdominal, you compress the thorax, and you narrow its volume. And then the internal oblique, transversus abdominis, and external oblique, all of these together also compress the space in the abdominal viscera, and that will push on the diaphragm. It helps it go up. It's going to also contribute indirectly to the compression of the lung volume. So the quadratus lumborum is a bilateral contractor. When you have it both sides contract, that enables you to rotate your trunk, and also it will help to compress the abdominal viscera to bring it in. The rectus abdominis, as I mentioned, it enables you to, when you flex or kind of lower or bend forward, it contracts to make you bend forward, and by doing so, you are going to compress the thorax and the abdominal viscera. You notice if you speak without if you speak without breathing and you continue to speak until you run out of breath, you notice that you will bend forward so you can generate more compression and make more air go out as you are speaking. So the internal oblique abdominis helps in rotating the trunk and the inflection of the trunk, and then the external abdominis, the external oblique abdominis, flexes the vertebral column and assists in rotation. So when you say oblique, remember, because some students ask me, what does the word oblique mean? And that's in the exam. Oblique means at an angle, as opposed to vertical. Vertical and then oblique, like at an angle. Okay, so this now brings us to the end of this part of, or this unit of respiration. And I hope that you listen to this more than once and pause it and take notes, and also read the textbook. And in addition, when you answer the questions in the CD, that will help you a great deal. You can always come back to these videotape lectures so that you can refresh your memories as you study the material. So thank you, and the next unit is going to be focusing on phonation. Thank you.